no be one a photo. Say we dey fight.
It is the senior most community pharmacist, Dr. Tuli.
Tompo Asembeng.
Oh, no lie. Then I say if your driver can't pick you, I make you people give me lift go. Shakes inside now. I'm gonna say it's on link copy. But
Tompo 11 p.m.
Oh, if it comes in for see the neighborhood, give me. I get some entanglement before that side.
You know they hear social distancing, eh?
To leap from D, same crowd, the whole. As I be young in the Emas are they cool. If you no go pick me to catch them in small lifts.
See, this be the problem. Who tell you say corona affects youngins? If you know they care about your life, if a guy say NSL over 50 years, away get hypertension, where poppy to be diabetic. Charlie them their go mess them up.
You are go wear face shield.
And that changes anything? That thing they protect only your eyes.
Plus face mask.
Charlie, the youth will they take this thing for granted. It may not kill you, but if it give you long-term damage to vital organs like your lungs, if you go get for outside cargo house, they give your OGs where them die. Will you be able to fend for yourself?
Chama, so I can say because unless I start, they do Yahoo, I enter Benino, na funeral cost me this the COVID itself make it left one at top hole.
If people know they follow simple directions like social distancing, hand washing, wearing face mask and things, the COVID don't go anywhere. And the way they make careless there, it be like you no go left with anytime soon.
So to you say my shadow make beans eh?
If you love yourself and the people around you, they house and take your shadow go back cry.
You are here, you more like a dog knee. So they kill my vibe cry, make a go take responsibility
and keep fighting with positivity.
All right, welcome back, viewers. As I said earlier, we have Kwame Sarpong Asiedu, and then we have Nana Kofi Quakyi with us. Welcome back, guys, and it's a pleasure to have you on again.
Thanks for having us.
Thank you.
Yeah, so we have a lot to discuss today, so I'll just want us to get right into the issues. And I'll start with Nana Kofi. So, Nana Kofi, regarding the COVID-19 situation in Ghana, what are the numbers telling us? This past week, what have we seen?
Well, what we've seen the last week has been generally a sort of stagnating of the test positivity rates. The general suggestion there would be that, we for the last week and a half, we've really been around that 15 to 20% range for positivity rates. February 2nd, or the data that's come in, February 2nd, we did have a bit of a spike where it went up to 30.5% for contact tracing, for positivity rates in that group. But for the most part, the positivity has stabilized at that very high rate. We are seeing, obviously, that we are detecting many more cases. Apart from a brief drop, I think, on February 7th, all the rest of the data has consistently still been about 700 cases. And we are quite obviously seeing that some of those cases are the ones that we are finding out about in schools like AIS and other academic institutions and workplaces where there are, some small clusters or small outbreaks right now. But overall, the picture hasn't really changed. We're not seeing the kind of improvements we need to see in positivity rates in new cases that we would want. The one good thing here is that we are still maintaining that relatively high rates of testing from January, where we are still testing in the region of 3,500 and 4,500 samples a day. And that is at least giving us a more accurate sense of where we are than what we were doing 2 months ago. So the overall picture hasn't changed much. We're still facing many of the same, trends that we've been seeing. And that would suggest that the desired impact from some of those measures around physical distancing, such as the reduction in capacity for funerals, weddings, and all those kind of things, may not be translating effectively, because we still know, especially with funerals, that compliance is not really where it needs to be. There are big ones happening in and outside our crowd still every weekend. And we know that as far as that's the case, it makes sense that we would not be seeing major differences or declines.
Yeah, thank you, Nana Kofi. Kwame, let me bring you in. So I just want you to add your thoughts to this particular thing we're discussing. And also, there's something interesting going on with our mortality. And I've seen some comments that you have put on social media about this. Can you speak on these issues?
Thank you. I think Nana Kofi has given the broad strokes about where we are, and that we are not getting worse, but we are not getting better. And that is broadly the case on a national level. But when you look at the micro data, you come to realize that that is the same picture. So if you look at, for example, though our numbers, average numbers per the active cases, are still over 700. Like Kofi said, there was a blip a few days ago when we went to 500, but it's mostly over 700. Our severe and critically ill is not changing as well, as much. It's normally above 130 people per day. But what is instructive is if you look at the period from the beginning, the end of January to the beginning of February until now, our average daily mortality has been creeping up. So we were something about 5 mortalities being reported per day. We went to 7, and last week we were at 8, now we're at 9. But the data coming up in the last 3 days indicates that the data for the next 7 days would be that our mortality would be higher. And why do I say so? Today, for example, the report coming in for the 9 points of mortality of 13. The previous day was 11. The previous day was 10, which is much, much higher than the daily reports for the previous 4 days. So it means it's going to go up. And why do I say that this is concerning? It is concerning because in epidemiology, mortality is the last result of all the activities that go on. So first people get infected, then out of those who get infected, some get mildly ill, and then out of those who get mildly ill, some will get moderately and severely ill, then some will get critically ill, and unfortunately some will die. So when you see your mortalities going up, it means all the other dominoes are going up as well. And so when you do the statistical modeling, which says that only about 1 to 2% of your cases from moderately ill end up as mortalities, it gives you an idea of the stress on our health system. Because what it means is that today, 13 people have died. We've gone from 505 to 518, albeit it's a few days back data being reported. But if that is 1% of our illness population out of our active cases, then what you have to look at is 13. If 10%, it will be 130. If it was 100, it will be 130. But we're looking at in our thousands, and then we're looking at 7,000. So that is the volume. So clearly, we've got a lot of cases that are being dealt with. And if you look at the number of health assets we have to deal with those sets of cases, then you realize that our mortalities might begin to get out of place because quality of care is going to drop. And that is why I've taken my time in doing the numbers first from front to back, and now I'm doing it back to front, looking at the mortalities as they are being reported now and what it should be telling us. So for me, that should be concerning.
Yeah. And Nana Kofi mentioned that our measures were not really giving us any significant impact. If under a minute, you can just comment on what he said. He made reference to the funeral still taking place and a few other ceremonies still going on. So if under a minute, just comment on what is going on.
Well, probably I'll use 10 seconds. The truth of the matter is, if they were impacting, the domino effect I just said would not be happening. It would be going in the reverse. Less critical, less severe, less mortalities, less infections. So the fact that it's going the other way confirms what Nana Kofi has been saying.
All right. Nana Kofi, let me bring you in for this one. So Parliament, as we all are aware, had to close for 3 weeks. What does this say about COVID-19 situation in Ghana? And our government is pushing for self-responsibility, personal responsibility in this particular pandemic. This is the case where our parliamentarians were not even able to practice that self-responsibility, and hence everything had to be shut down. But we have schools open. I mean, what does this say about our situation?
Well, I think it puts into context why the suggestion that what's supposed to happen here is solely an issue of personal responsibility. It highlights how that suggestion is not really grounded in the broad contextual realities of public health communication. People take their cues from the people who are giving guidance in broader public life. We are in a situation here where most people are not public health experts, and most public health experts are not even pandemic experts. And so a lot of people are trying to apply their discretion as well as they can to interpret the information they are getting, to interpret their understanding of the risk around them, to form some kind of assessment of what they need to do, how seriously they need to take precautions, and how they ought to act given what the risks are. One of the cues people take is what leadership does. It's not for nothing that, as we said many times here, the issue with the election season was not just merely the question of transmission. It was partly the question of normalizing bad behavior during a pandemic because the people at the top didn't seem to believe there were consequences for it. That's something that carried on in the general public. Now you have to start with, you have the speaker requesting all parliamentarians to get tested, 60 of them basically refusing to until they were threatened with sanction if they didn't. Then of the 275, 16 of them getting infected, and many of those refusing to quarantine or isolate in this case, despite knowing their status. And then for them to keep coming to work, for Parliament to keep sort of tolerating that behavior where despite the knowledge that there were actively infected people still come to the chamber, nothing was closed, nothing was done. I mean, you can think there about what that does, what that says about workplace management or what workplaces take from that. But then you go on to have the consequences where out of the first 500 staffers tested, 115 were positive for COVID-19. That's a 30%, like a range of 30% positivity rate.
Right.
You have to wonder, you have to wonder what kind of cues that sends to people about how real the risk is, what kind of signals it sends about how you should behave if you're infected, or how you should, or what measures you should take if you've been exposed. And it speaks a lot to the challenge we're having with controlling infections in the workplace, where because there's no strict guidelines or specific guidelines given support for situational decision making, people are applying their discretion in the workplace. And we're seeing how even at Ghana's most famous workplace, that is still applied there, that's applicable there, and how it's having consequences for the failure to limit infections and failure to control infections.
Yeah.
I hope that as part of the measures that Parliament has taken at the end of these 3 weeks, they will actively push to make sure that there are existing workplace guidelines that other offices, other workplaces can follow to avoid the same situation, and that they start to take seriously their responsibility about being ambassadors for good behavior, especially if one of the main themes or one of the main focuses of our version of COVID-19 management here in Ghana is to say that personal responsibility counts. Then you must set good examples and give a good framework for behavior that people can actually follow, and that actually allows people to understand that these things must be done because the risk is real, and if we don't take those things seriously, we'll fail at infection control, and there'll be consequences, because obviously those 115 staffers don't live together in a one-bedroom self-contained.
Right.
They have families, they live in communities, and all the time that they were coming to work, getting infected, going home, knowing that there was a risk from infected parliamentarians, all of that is stuff that is going to definitely, there'll be some people in those transmission chains who will require clinical care or critical care. Some of them might not be able to get it. And all that comes from the irresponsibility of some 15 or 16 people, not all of them, but some portion of them, and what that means for their staffers and the families and the communities.
Right.
So I hope we take this one seriously and really demand some accountability and honestly a public apologies for the behavior that's resulted in this kind of an outbreak there.
Whether we get that is something that, we'll all wait to see. But there's another issue that I want to bring Kwame in to talk about. Airport testing at our airports. There's so much that has gone on. I just want us to talk about this. Just briefly, if you have any comments with what's going on. For instance, there are issues about the antigen test, which a lot of people complained about. We had a lot of, complaints with their ability to detect cases, how things would go through the cracks. And now there's so many other, I don't even know how to go on with this particular one. If Kwame, you have any comments on the airport issues, I'd want to hear them.
It's interesting. If you look at it from a testing standpoint, as a quality control, quality assurance professional, the first thing you do with any test is to say, what's the gold standard? Because for every testing regime, you would have a gold standard. In this particular instance, the gold standard is PCR. Yes, there is ELISA, but how many people use it? So the gold standard is PCR. So any test that is coming in should be as close to PCR as possible. The first anomaly was that we were giving the impression that the antigen test that was coming in at the airport was virtually identical to PCR, even though reporting a sensitivity of 87%. But for some strange reason, all the communication kept saying 99%. That's fine. Because then the explanation they gave was it was because for the samples they tested with PCR, the antigen test was able to identify 99 out of 100 of them. So they said 99%. But that was strictly accurate from a quality control and quality assurance standpoint, because what the manufacturer had said was that out of every 100, 13 would be missed. Then the next thing was that for a test that was subsidiary to the gold standard, we were charging more than what airports that were doing the gold standard were charging, ostensibly because the argument was that if we had done PCR in the airports, people would have to go and stay in hotels for at least a couple of days for the PCR and results to come. And I remember on another program with Quakyi earlier, when all these debates were going on, me pushing back and saying the PCR coming 48 hours later is nothing to do with the frequency and speed of turning out a PCR. It's got to do with the more of the pressure we put on our systems. And if people would be currently, there are private providers who can test and give you your results in 4 hours, who can test and give you your results in 12 hours, depending on how much you want to pay. That is a tacit acceptance that PCR turnover doesn't need to be that long. But that was the reason that, therefore, if you're going to stay in a hotel and you're going to pay, let's say, $100 a night or $150 a night, and at least you are going to stay 2 nights and pay for a PCR test, then charging you $150 for a 30-minute test was affordable. I found that as outrageous an explanation to give from a scientific or affordability standpoint. Now, moving forward, suddenly there was an ECOWAS meeting, which was chaired by our president, Nana Danko Akufo-Addo, and it was agreed that for ECOWAS nationals And listen to this clearly. PCR testing should not cost more than $50. And the communique is available. It didn't say testing, PCR testing. They were specific about the testing that should occur at ports of entry should not be more than $50. So what did we do? We decreased our second rate, which is not a gold standard PCR, to $50. Now here's the question. If the company is making, because the argument is that it's been reduced for Ghanaians and ECOWAS nationals to $50. All other nationals pay $150.
Mm-hmm.
Through our airports, by and large, over 85% of all passengers are Ghanaian or West African origin. So if we can charge $50 for testing for the majority of people who use our ports, and the company would still make a profit, then the question I would ask is, why did we start from $150? Especially when you go into the biomedical markets and you realize that the lateral flow test, which is antigen test, ranges from $3 to $12, depending on where you're buying it on wholesale. So you can talk about them having to put infrastructure, you can talk about them having to pay staff. But even if I go with the upper limit of $12, and I assume that you pay staff, equipment, and other things, even $30, which is exorbitant because there's no one who will put any infrastructure in place that the staff component will be more than the testing component. We all know that. We all work in senior management, we all researchers and all that. And we know that that doesn't happen. No organization would pay their staff more than they pay for the HPLC, for example, or their UV mass spectrophotometer. It doesn't happen. But we're charging $150. So now we're charging $50. That's fine. You can accept that in that case, we have decreased that price, but we're still charging the foreign nationals $150. Let's park that. Then we say, okay, our parliament is the highest authority in the land. We're in a country where there's a law for freedom of information, but it cannot, and it doesn't work. The average person cannot get information even if they invoke the freedom of information law. Our MPs are vetting ministers who have to then become substantive ministers because at the moment they're designates. And there's a health minister appears, is asked, did you see the contract? Says no. And then you ask why. So the decision was made by the Presidential Task Force on COVID. He's asked, are you a member of the task force? He says yes. Say, but you said the decision was made by that task force. You are a member. So yeah, I still didn't see it. Then park that because this is a public health pandemic and public health comes directly under the forte of the health minister. So park that because I cannot accept that the person is being honest with me. Then the foreign affairs minister, who is in charge of the airport, also comes and is asked, have you seen the contract? No, I haven't seen it. But we are told the airport authority, which is a statutory body under the Ministry of Foreign Affairs, was the one who is the procurement entity because our procurement law says you cannot procure anything without a procurement entity. So the task force is not a procurement entity. The what the airport authority is procured it. The minister directly in charge have not seen the contract. Okay, that's fine. Let's assume they're all telling us the truth. Then the deputy health minister, who was the linchpin of that task force and in charge of this, goes on national radio on Joy and then says, I've not seen it neither. And you're like, what the hell is going on here? So who's seen this contract? Okay, let's assume they've all not seen it. But contracts are legal documents which a country goes into on behalf of its citizens, and therefore there needs to be a legal input. So who is the legal officer for the government of Ghana? The Attorney General. The Attorney General designates who was the Deputy Attorney General, because there were two Deputy Attorney Generals, but this was the one under whose forte all the comes. And is asked, Kofi Dami, who's my junior at Asiedu College? Have you seen it? No, I didn't see the contract. And you are like, what the hell is going on here? So who gave the legal advice? And you then ask yourself, is this a comedy of errors or what? And so with all that going on, it comes across as though people want to treat us as idiots and are just not prepared to answer the question on, have you seen the contract? Because if you don't answer, have you seen the contract, then the next question would be, who is the contract with? And then you have to talk about Frontline. Who owns Frontline? And then you can start picking the dot. But if I've not seen it, you cannot ask the second question. Right. You need to continually dwell on, have I seen? Because if I've not seen the contract, you can ask me, who's the contract with? And then I don't have to answer because I've not seen the contract. And then if I don't have to answer who's the contract with, then I don't have to answer who owns it. And the veil of ownership doesn't need to be lifted. And I'm like, we live in a country of laws. How can we be operating such a kamikaze system? And that is my view about the airport situation.
Yeah, let me bring Nana Kofi in for a few comments. Nana Kofi, I think Kwame has said a lot. If you can just add a few comments before we move on to the next topic, which is vaccines, also very important. So Nana Kofi.
I think Kwame has laid out what appears to be a series of rather confusing and unfortunate facts around, the nature of contracting for the testing. So I'll leave that contracting part alone because it's been well discussed. My concern about the testing at the airport is in the stuff that went into justifying it and the things it implied about what we could and could not believe and could not do about and with our COVID-19 strategy. We had a situation here where, like Kwame rightly said, the Deputy Health Minister came out and was a very vehement defender of the COVID-19 antigen test at Kotoka Airport. There were times where, in the way he communicated it, he would repeatedly say that, this test had a 99% sensitivity, and always portrayed the antigen testing that's going on at Kotoka as though it was a particularly unique solution that came at an opportune moment that couldn't be passed up, and that because of its high sensitivity, the pricing made sense because it would allow you to eliminate quarantine, which was implying that this was something that was so field-proof that quarantine, a public health best practice for 6 centuries, would not be something that would be necessary here because the testing was good enough to pick up cases. Now, the claim about whether or not it was 99% sensitive, that requires us to also sit here and believe that if there was enough testing, or the testing Ghana was representative in a way that the for-profit manufacturer of this device was underselling the sensitivity of their device, when they had a device that somehow was as sensitive as, PCR testing, were voluntarily choosing to undersell it as just another antigen test, which is what it is. It is just another antigen test. This is the Afia COVID-19 AG test that is performed with the Afia 6 system. These are tests that can be bought and purchased basically for under $20 a kit. The devices that you actually use to run the tests on the Afia 6 system goes for about 4,200 a unit. So even if you bought 40 units, as I think is the number we're using at Kotoka, a single day of arrivals at Kotoka Airport on the first day, 111, I think it was about 1,100 arrivals, would have been enough to defray the total cost of all the equipment that went in there. When we say that we have to put in infrastructure, what are we talking about here? With the exception of those devices, we're talking about PPE for the staff, and then we are talking about dividers and line management and crowd line management tools or queue management tools over there. Those things on the second day would also all have been paid for very, very much comfortably. So the rest of it becomes a question of then what was the pricing really based on? Because obviously it doesn't appear to have gone through any critical review. It doesn't seem like anybody who should know about it knows about it. And it does seem basically from, if you listen to what the former Deputy Health Minister has been saying on radio last week, that, this is a price that was paid because, quote unquote, we live in a free market and we're not in a controlled economy, which is basically an excuse for saying in a public health crisis, some profiteering will happen because we live in a free market. Because people who understand the way these things are costed know that $150 is an absurd price for an antigen test by any measure. It's more expensive than 2/3 of PCR tests that are conducted in America. And those tests include health insurance profits.
Right.
And so we're sitting here, justifying things that are not justifiable. But in the justification of it, making these weak arguments the basis for a trade-off between, this kind of testing system and quarantine. And now we know that, I heard, the former Deputy Health Minister saying today that we should look at the 1,100 and something cases that were detected at Kotoka, and know that the system caught those. But we can also do math and know that the 12.5% of cases they would miss amounts to about 166 passengers who went through directly into the public. So when in the other breath you're saying, and we should be mindful that it caught all these people because only 2 cases started the pandemic, what should we say about the 166 that came through with no quarantine? And that obviously have had a role to play in the current surge, because that is how the B117 strain got here. So it's something that is very aggravating for me on a personal level, because it was bad science, backed up by bad faith, presentation of what this test could and could not do. And that also undermined our public health effort by making it seem as though quarantine would not be a necessary thing here in this situation. And I hope that we will see more demands for accountability and ultimately get some real answers about what the contract says, and some accountability from the people who said, in June, July, in August and September, that, they had seen that due process had been followed and that everything was kosher, like the former Deputy Health Minister said. So I hope this will not just die out like regular issues in Ghana, because this is costing lives right now in this country.
Things for us to discuss. I'd want us to cover everything. So, moving on to the next one. I know with the airport testing, if we decide to spend time on it, we're not going to leave. There's so much in there. Now, let's go on to talk about vaccines. And if you can, in 2 minutes, just tell us what we are doing regarding our receipt and distribution of vaccines. This question was posed last week. You said some amount of work had gone into it, or you heard some amount of work had gone into it. Can you give us updates, if you can be brief about this?
So currently, the target that has been set by the president is 17.6 million doses by the end of June 2021. We know so far that we can expect about 2.4 million of those doses to be Oxford AstraZeneca vaccines that we are getting through the COVAX facility. The question then is, what about the remaining 15.2 million? We are not too clear about exactly where those are going to come from. We do know that we will have access to vaccines through the African Vaccine Acquisition Task Force, which has distributed about, I think they said on February 4th that 16 countries combined had ordered 114 million doses. We know that between Kenya, Nigeria, and Zambia, that's about 47 million. So the remaining 70 million for those 13 countries is what we are trying to figure out. We're not sure if Ghana is one of those or if we've applied because we're not getting the information from the AU right now, and the local health authorities here have also not been clear on that. But we know that we're going to be leaning very heavily on those AU supplies to get to that target if we're going to get there. We know also that we are very much going to now be restricted to Oxford AstraZeneca vaccine and then other ones that can be stored at that temperature or warmer, because it appears that we are actually making a specific commitment to stick within the constraints of our existing cold chain infrastructure, which will rule out the Pfizer and Moderna options to us entirely, because if we are not going to invest in putting that cold chain infrastructure in place, then we won't be able to take delivery of that. And what that will mean long term is that basically these mRNA vaccines that are easily adaptable to new variants will not really be an option for us throughout the pandemic, which will mean that as new variants emerge, we will always be slower in responding to them in terms of vaccinations and acquiring herd immunity against them, because the vaccines we can store will take maybe 6 or 7 months to catch up with the variants.
Okay, Kwame, Nana Kofi talked about the new variants. He mentioned the B117, which we know is the one driving the pandemic in Ghana. Now, there's been some communication about the vaccines in South Africa, the Oxford AstraZeneca vaccine, to be precise. There's been some, information, whether it's been stopped, whether it's been paused, whether it's been halted. Can you just clarify what exactly is going on with this particular issue?
It's rather murky when it comes to the South African variant and the Oxford AstraZeneca vaccine, because the truth of the matter is there was a small study carried out in South Africa with about 2,000 patients, which found that when it comes to mild to moderate disease, the vaccine was effective in just about 10% of cases in preventing that happening. But that was a very small study, and it had no variance as to what happened in severe infection. So the South Africans held a press conference, and I was on that press conference, at which they said that they were going to pause, and that's the confusion that came. They were going to pause their massive rollout and rather trial it in 100,000 health workers to get an understanding of what was going on. You need to bear in mind that at this point in the pandemic, the major thing is to prevent severe disease, hospitalization, and death. And so they were like, if we can establish that in our health workers, because if your health workers are off, then you're losing the pandemic fight, because you need them to be at the forefront. They are the key workers to be at the forefront. However, for some strange reason, after that press conference last Sunday, it came across as though South Africa, one, had stopped the AstraZeneca. And it got further complicated, because then South Africa, not naively, but unfortunately, went on to say they wanted to pawn off some of the vaccines they had gotten from Serum Institute, which were AstraZeneca vaccines. So it gave the impression that it wasn't going to work for the South African variant, and they wanted to sell it off to others. The truth of the matter was that wasn't what was in the communication. What was in the communication was that they had received vaccines that were manufactured in November. And for people like Kwame, yourself, and me, who work in quality control and quality assurance, we know that for biological products, the shelf life is 6 months. So those vaccines were going to expire in April. And they had ordered the quantity for the mass vaccination drive. Now they wanted more data based on their health records, which meant that by the time they get to the mass vaccination, probably some of those vaccines would be expired. Therefore, the decision was that let's give it back to COVAX and the African Initiative and all that, so that countries in these organizations who are starting their mass vaccination but do not have the South African variant can use them, because the WHO has said no vial of vaccine should go waste. So South Africa was trying to play ball to ensure that that dictum from the WHO happened. Unfortunately, the press read it differently and different publications were put out, which led to the WHO coming in last Wednesday, holding another press conference. So the SAGE, which is the Scientific Advisory Group on Emergencies for the WHO, held a press conference. I was on that one as well. And I think I sent you even a link to go and watch the press conference so that you could also hear verbatim what was said. On that press conference was the Chief Scientific Officer of the South African government. And he was clear in reiterating what had been said 3 days earlier on the Sunday, and exactly what I'm saying, that they had paused and hadn't suspended. But the WHO then said, based on the data from the larger population globally, the AstraZeneca Oxford vaccine was the most viable, especially for countries like Nana Kofi has just said, who didn't have the extreme cold chain facilities and had to rely on their ambient cold chain facilities. So this brings us to the point where anti-vaxxers, vaccine hesitancy players have then picked on it, and it's going all over the place on social media. The simple thing I would want to say is that for those of us who realize the merits of vaccination, realize the strength of the chart that science has had to go through to get vaccines in less than a year for COVID, need to be putting some of these information out, like you showed the slides from the South African presentation, and challenge those who are putting this pseudoscience to actually speak to what actually happened. Unless we do that, we would lose the fight and people would be very reluctant to take this vaccination. I'll end by saying this in 1 second. That even in the UK, currently 9 out of 10 people are taking the vaccines. But when you come into blacks, it's less than 30% over the age of 80. If that continues, we would disproportionately die. And for me, that would be a travesty for public health.
Educate people on vaccines and let them know of the benefits. All right, thank you, Nana Kofi. Let me bring you in to take the next question or the next part of this discussion. So this is on the new variants that have come into the country, right? And when the genomic sequencing data that was conducted in January was revealed, we became aware that it was the B1117, which is the predominant strain in the UK, that was driving the infection, right? So we know there was a traveler that came in from Tanzania who was known to have the South Africa variant. Now, this wasn't picked up in January. What are the updates on that? Do we have that in the system, or do we have to wait for another set of genomic sequencing studies to identify whether we have that?
I think we might have to wait a bit more time for another round of the genomic sequencing, because I believe the UK variant that was identified for the first time in early December. And if you look at the time it took, for example, in the UK for it to go from 3% of sample sequence to 81%, so it was about a month. And if you look at what we are reporting on 90%, that took about 6 weeks in the UK. And that seems to be about the time frame here as well. The South Africa variant, I think, was identified later than that. I want to get the exact dates correct. So it's unclear how representative it was in the sequencing, but we do know that at least in the at the airports from the genomic sequencing of arriving travelers, the South Africa variant was identified in quite a few. In fact, even with the UK variant as well, it was identified in mostly travelers coming from other African countries, not coming from the UK or Europe. So I think that suggests that, you know, we're just about to start seeing maybe more surveillance for that samples collected in that late December, January window, which will inform the sequencing we're going to be getting out maybe at the end of this month or early March. So I think it's important to put that time lag or time frame in context. But so far, we do know that was checked at the airport. It doesn't seem to be being picked up in the community testing from the genomic surveillance that was done. But let's see, you know, another round that's done with more, you know, with more samples tested. I hope we can scale up the end for that genomic surveillance to maybe about 1,000, 1,200 samples every cycle, and more nationwide, so we can get a sense of that. But that's the picture for genomic sequencing right now and where the variant stands.
Okay, all right. Thank you, Nana Kofi. So there's another question. Current existing vaccines are still being distributed, or we are supposed to be still having other vaccination programs going on in the country. Do you have any idea how these are faring? I mean, vis-a-vis trying to get ready for COVID-19 vaccination in the country?
Well, it's not too clear right now how the other vaccination programs have gone. We know for a fact that the Ghana Health Service did put in place and did activate all its usual structures for vaccinations for yellow fever, especially, and the other childhood killers that it does exceedingly well every year. We know that in 2019, I think the average coverage for the expanded program of immunizations was about 92% on the low end for the different vaccines that were involved in that. And we know that that infrastructure, again, like I said, was reactivated this in 2020. It's just not clear how successful it was at identifying all the people and also getting all the people to come and take the vaccines, especially because some amount of the vaccination work that goes on through the Ghana Health Service is from, you know, care-seeking opportunities. So people coming into CHIPS compounds, district hospitals, teaching hospitals, and while they're seeking care at those places or clinics within those places, you know, being invited to get vaccinated through there. We know that a lot of facilities also have to do outpatient department closures to make room for COVID-19 treatment. So that could also have affected the reach of those kinds of, you know, institutional vaccination programs. We're just not clear on what the data says right now, but the Ghana Health Service did go out and attempt, as it does every year, to meet its obligations in that respect. Okay,
all right, thank you. We are actually 5 minutes into the second segment, but there are two questions that I want us to deal with before we leave. And let me bring in Kwame to take this one. So Kwame, two issues: long COVID and reinfection. You've talked about this at length. Nana Kofi has also spent a lot of time talking about this. There's been a recent case which is actually being talked about a lot. There was a recent publication on it in France where somebody has gotten critically ill from contracting another variant from, even though he had a previous infection 4 months ago. Like I said, you've talked about this at length. Just say a few words on the reinfection for COVID-19.
Thing is, we all know reinfection are real because while COVID exposure gives you immunity for 3 to 8 months, the mean is about 5 months. So 4 months is perfectly fine that they got reinfected. Unfortunately, the data is also suggesting that the second infection leads to a hypersensitivity reaction for some people and an autoimmune response, which then means that your likelihood of being very unwell with your second infection is high. But the truth of the matter is this should be expected because that is the whole essence of the booster jab when it comes to immunization. They want your immune system to react more vigorously so it can use antibodies to protect you in the future. So basically, your immune system is actually doing what is expected of them when you're exposed in the wild on 2 occasions. Just that because the exposure is wild, you are fighting a disease and not fighting a primer. Because a vaccine is a primer, it primes the immune system, it trains the immune system. Whereas a wild exposure is an infection. It is there to make you unwell. And that is the reality that the Ghanaians need to draw the attention to. A lot of people who were infected. So when I look at our data, we had over 60,000 cumulative cases. I always tell people who want to listen that about 45,000 of those are due infections now, because they were infected from March till about September, October. So they are eligible if unfortunately or fortunately they didn't die by the first infection, their immunity has waned and they are due to potentially be reinfected. And therefore, until we get the vaccines, the protocols are your vaccine, whether you've had it before or not. If you don't comply, you are putting yourself at more risk than you were when you were first infected.
Yes, so you've heard it. The protocols are what are going to protect you until we get our vaccines. So at this point, I'd want us to bring this first segment to an end. Let me invite Nana Kofi for final comments. After that, we'll move on to Kwame briefly, and then we'll head out.
For this week, I think the big takeaway is to keep an eye out for what we're going to hear, or to see if we do hear anything about vaccine supplies coming from the AU. That is really going to determine whether or not the president's 17.6 million dose target is going to be hit. And I'm hoping that as the AU begins to deliver or roll out deliveries towards the end of this month, we will see some more clarity about that and get a sense of what we can expect.
All right. Thank you very much, Nana Kofi, and we hope to have you here with us again next week. Kwame,
My pleasure.
let me bring you on to give your final word, and then we'll head out.
It's clear that on the basis of our numbers, on the basis of our mortality spikes, the interventions that were introduced by the president 2 weeks ago have not really brought community spread under control. I'm hoping we hear from the president tomorrow, and I'm hoping more action is taken because our numbers as it stands don't look great. To the average Ghanaian listening to us, I would want to say we are in self-preservation mode now. It's now not anything to do with what the president says or what I say or what Nana Kofi says or what you, Kwame, you say. It's about realizing that the numbers that I quote, Nana Kofi quotes, or anyone who speaks on quotes, are human beings. The dead are people like you and me who were speaking last week, but unfortunately are lifeless today. You can prevent that from happening to you by complying with the protocols. And that's how I want to leave it.
All right. Thank you very much, Kwame. We really appreciate you being with us again, and we hope to have you again next week. So thank you very much, Kwame.
Thank you.